Happy to be joined today by some old and new friends and colleagues, Rosanna Weaney and Rebecca Kurt. I will let them introduce themselves, but how many of you think drug prices are too high? Yeah, too darn high. We heard about this morning in our session. The keynote session, one of the conversations was drug pricing and how it affects all of us, whether it's ourselves, our family members, our loved ones. The price of drugs definitely affects all of us. And the reality is that there's still many drugs that are priced out of people's reach, right? There are many people who can't afford, especially some of the newer, really expensive, right, life-saving drugs. And so, there's been a lot of legislation recently to try to, fix some of that. Some real major drug pricing reform, especially in the Inflation Reduction Act of 2022. And so, what we're going to talk about today is what was the real world impact of one of the provisions in that act, which was to put a out-of-pocket price cap on insulin for people with diabetes of $35 in the Medicare program. What happened? Did it have any impact? And so that was some research that we conducted with the Pharmacy Quality Alliance with Roseanne as the project lead there. And so we're going to tell you what happened, what we saw happen, but then we're going to turn to a more important discussion of the broader implications of the price of drugs and the cost of medications and the cost of treatments on consumers and on patients. And that's where Rebecca's expertise particularly comes in. She focuses on that every day. So before we get started, we'll introduce our panel. I'll let you introduce yourselves. I'm Christy Toglin. I should introduce myself. Vice President of Research Science, Advanced Analytics at Inovalon. Been there a very long time, more than a decade, working on issues like this, which keeps me coming to work every day. So Roseanne, please tell us a little bit about yourself.
Thanks so much, Christy, and great to be here with you all today. I'm Rosanna Weaney. I'm a Senior Manager for Performance Measurement at the Pharmacy Quality Alliance, or PQA. I'm a pharmacist by background, but now work very closely with the development and maintenance of quality measures in the space of medication use quality. Also get the chance to work on some innovative and interesting research projects, which we've done with Inovalon in this project today.
And I'm Rebecca Kurt, based here in Washington, D.C., and I handle health policy for the National Patient Advocate Foundation. So we focus very much on patient and caregiver engagement in policy development, research projects, insurance benefit design, and with particular attention to patients and families who are experiencing financial hardship.
Great. Thank you both. Let's start with a little bit of background, recalling what the provisions were, including that insulin price cap of the IRA Act. It first allowed Medicare price negotiation, and we've been seeing that happening, right? They negotiated the price of 10 drugs to start out. People thought the world would collapse. It did not. They recently, in March, announced they'd reached negotiations on 15 other really big, widely used drugs in the severe mental illness space, COPD, cardiovascular, covering a lot of spaces. These drugs, even prostate cancer treatment drugs, GLP-1s, right? I don't know if we've seen the price drop too much in those, but or when these negotiations will go into effect. But that was a big provision. Inflation rebates. It really capped the increase in annual increase in the price of drugs at the rate of inflation or below, or else you'd be penalized. A big provision limited the out-of-pocket expense, total yearly expense, to patients, to Medicare beneficiaries, to $2,000 in the Part D program. So that was a big change, expected to have a big impact on seniors. And then vaccine cost sharing for adult, of vaccinations covered by the Part D program. And so hopefully improve access, right, to those treatments. So we're going to specifically focus on the insulin cost cap that went into effect in January 1 of 2023 in this study. But before we start, Roseanne, tell us a little bit about why this particular policy change is so important.
Yeah, certainly, that $35 monthly out-of-pocket cost cap for insulin, we would expect to improve affordability for our Medicare beneficiaries who are using insulin. But beyond that, we know that diabetes broadly is a huge driver within Medicare of costs and of health outcomes that are costly to Medicare and also are negative patient outcomes. We know that diabetes is one of the leading risk factors for other conditions like heart disease and stroke, as we have on the slide here. It's the 7th leading cause of death in the US as of the last several years, and we know that it impacts nearly 1 in 10 Americans here. So on top of that, even just the cost of medications for the treatment of diabetes, we've talked about the blockbusters, right, the GLP-1s and the like, but even insulin, which is such a cornerstone of diabetes treatment, has become so unaffordable for patients over time. Out-of-pocket costs for insulin specifically in Medicare have more than tripled for patients in the period from 2012 to 2022. And we have heard those news stories, right, of patients rationing their insulin, going without it, having to figure out other ways to try to manage their diabetes because they're not able to afford their very important insulin. And so with this cap, we have maybe had hopes that it would improve the quality of care for those patients who are reliant on insulin therapy, as Christy mentioned. So within the IRA, that cost cap went into effect January 1st of 2023, with the hope being that this would lead to improved access for patients, reduced interruptions in their care, because maybe they are hopefully more able to afford that care. Now, we'll get to in just a moment about what we looked at in this study, but we know, just broadly speaking, whether it's insulin or it's most other medications, patients remaining adherent to their therapy is linked to improved outcomes, right? Kind of the first step is making sure they have their therapy, and the second step is making sure that they're actually using it appropriately. So with insulin, kind of tying those two things together, are we getting that access, and is that leading to improved use of those medications?
Rebecca, from the patient perspective, from the consumer perspective, not only this price cap on insulin, which is the huge numbers of people with diabetes, tell us a little bit about, how if we had a bigger focus on affordability for all the chronic conditions, all the major chronic conditions, and how similar price caps might impact patients.
I appreciate the question, because the constellation of concerns that patients and their families have when any kind of chronic condition rears its head in a family's environment is the out-of-pocket cost sharing pressures can be very, very real. And so opportunities to think about in the broader world of putting food on the table, being able to afford their housing, transportation, all the things that are part of the scene once complex or chronic illness comes into play. Price caps around cost sharing are one important solution, and I think the evidence in this particular study is very illustrative of the opportunities. It's not the only one. There are a number of things that still affect patients beyond the price of drugs, but it's so true. They are splitting pills, they are rationing all the time, and the opportunities to sort of listen to their biggest priority concerns, I think, is paramount as we think about how prices get negotiated, how discussions happen around setting them, how insurance benefit design fits in based on the realities of what patients and families are experiencing every day.
And we're going to talk about that a little bit more later, how it's really so important to involve patients early on and often, right, in all of these decisions. So Roseanne, we used a new measure that was developed by PQA, a lengthy time frame it always takes to create these new measures, but it is now, it's not only important because we used it in our study, it's important because it's now on the CMS display page, meaning it's going to impact star ratings at some point. I'm not sure if you have a date for that, Roseanne, when they'll go live in the 5-star program. But so it's a very important quality measure. And so, think about if you're a health plan, what the impact of improving your performance on this measure might be. So it's a little tricky though. So I'm going to let you talk us through it a little bit, Roseanne.
Sure thing. So like Christy mentioned, the study that we undertook utilized an existing health plan quality measure called persistence to basal insulin, or PST-INS, as we like to shorten it. So as I mentioned earlier, I work for PQA, Pharmacy Quality Alliance. We are a quality measure developer, researcher, educator, and convener, among some other roles. But we developed and stewarded this quality measure. And that process started back in 2018, even a little bit earlier than that. And this measure was developed to fill a specific need within the Part D quality program. So if you're familiar with the quality measures currently in Part D and those that have been in the Part D program, there are no measures that specifically evaluate the quality of insulin use specifically. So there are other measures that look at diabetes care, but insulin actually is not assessed within those measures. So PQA is a multi-stakeholder organization, and this was brought forth as a high priority of a measure that needed to be developed. And back in 2018, PQA convened a roundtable kind of multi-stakeholder group to inform how can we assess the quality of insulin use. And so that was decided upon to be something that looked at either adherence or persistence to basal insulin, related concepts, though not identical, and the development, or rather the adaptation of a methodology that had been reported on was used to develop this measure. So moving forth past 2018, PQA went through its standard consensus-based measure development process to define everything related to how we were going to evaluate persistence to basal insulin. So how do you identify that denominator population, the numerator, who should be excluded from the measure, how exactly do we define persistence, among other things. And after the conclusion of that process, PQA's membership endorsed the measure in 2021. To that point, kind of made that measure available to be used. And there was a very quick on-ramp, I'll say, from there of this measure being added into CMS's Part D program. So that started in 2022 when it was first added to the Part D patient safety reports. So the patient safety reports include measures where rates are confidentially shared with plan sponsors. And then what happened shortly thereafter is, as of 2023, like we said on January 1st, is when this out-of-pocket cost cap went into effect. So that $35 monthly cap went into effect in 2023. Following thereafter in 2024 and 2025, this measure moved from the patient safety reports kind of to the next rung of the Part D ladder, if you will, which is the Part D display page. So measures on the Part D display are publicly reported. So as of now, this measure sits on the Part D display where patients, plans, et cetera, folks can see how plans are performing on this measure, which evaluates, again, persistence to basal insulin. I know, Christy, you mentioned that perhaps this means that this measure will be moving into the star ratings. We don't have any clear indication yet. I'll caution that that does come from CMS, either through its rulemaking process or other processes there that could potentially propose this measure. But we do see this, or view its journey so far as it being sort of a rising star within the Part D program, and one that CMS has clearly indicated is of importance to evaluate.
Mm-hmm. I mean, we all know that there are already 3 medication adherence measures in the Part D 5-star rating system. also developed by PQA, by the way, and even have some risk adjustment now, which is really important because almost none of the CMS quality measures have any risk adjustment at all. So that was exciting to get those updated. But persistence is very different from adherence, and that was something we chewed on a bit in this study. But you did some other research that was published, Roseanne.
Yeah, so just wanted to highlight here that, we talk about quality measurement sometimes kind of in isolation of we're just calculating some measures and spitting out some numbers, and what exactly does that really reflect? And this study in particular, which included PQA with some other collaborators, really served to show and validate that the methodology that's used within this quality measure is associated with improved health outcomes for that type 2 diabetes population. So this study showed that when you measure persistence to basal insulin, as done within this quality measure, it showed that those patients who are persistent have lower hemoglobin A1C compared to those who were not persistent. There are fewer emergency department visits and hospital readmissions, and importantly, lower diabetes-related medical costs. So what we really are demonstrating by evaluating persistence using this measure is, are those patients being set up for those improved health outcomes?
Right.
Just kind of another note here, the study also didn't show any increased risk of hypoglycemia either, which I know we're always concerned with insulin as well. So overall, really strong takeaways that improvement in performance on this measure really is also tied to improved health outcomes and economic outcomes for these users of insulin.
Mm-hmm. And of course, HbA1c is also a measure in the 5-star rating system. So it has very broad implications for cost and quality and healthcare use across the board. So what was the real objective of this study? So Inovalon obviously has a lot of data, right? And we've got a lot of Medicare Advantage plan data that's very recent. So we were able to take, what the persistence rates were on this measure in 2022 before the cost cap was implemented, and compare that to the rates in 2023 after the price cap was implemented in 2023. So we had full year data of 2022, full year data of 2023. So in other words, you're a health plan, you could compare your rate in 2022 and see if your performance improved in 2023. So that was really the goal of the study. And drum roll, let Roseanne share the top line findings here.
Sure. So like Christy said, we were comparing those 2022 rates in persistence to 2023, really that first year of the implementation of this cost cap. And we found some promising results, which is that there was a modest but statistically significant improvement in overall persistence in that Medicare Advantage sample that we looked at. So an improvement of 1.3 percentage points, as I mentioned, that was statistically significant. And I think, when we contextualize this, both in the realm of quality measurement, trying to move the needle from one year to the next on how you're scoring on these measures is difficult, right? It's those small changes really do have a large impact, and it is hard to get those changes from one year to the next. Additionally, contextualizing this to the broader Medicare population and the users of insulin within the Medicare population, this really equates to thousands, if not tens of thousands of additional beneficiaries who are now persistent to their insulin who were not before. And of course, we can't directly attribute this to the policy change. This was not a randomized controlled study or anything like that, but this was a very significant policy change that coincided with this change that we're seeing in persistence, which we view as very promising to potentially the impact of this policy on how patients are actually using their insulin.
Mm-hmm. Yeah, and just to reinforce, a change of 1.3 percentage points doesn't sound like much quantified, but but in a population measure, that's a huge change. And if you think about the millions of people with diabetes, that are impacted with that now being persistent when they weren't before. It's a pretty strict measure too, Roseanne, right? You have to be persistent for the whole year with just a few gaps or something. So it's pretty tough to get into this measure, right? I think some of the more interesting findings that we found, Roseanne, were some of the differences in different populations with diabetes. So tell us a little bit about that.
Yeah, and I'll say that what was really great about working with Inovalon on this project was the extensive data that you all did have access to, which allowed us to do a lot of these subgroup analyses to see, we saw this 1.3% improvement overall at the population level, but what did that really look like in certain subgroups? Were there certain subpopulations that benefited more or less potentially from this change in the out-of-pocket costs? So we did note a few subgroups here that had more pronounced improvements than that 1.3%. So listed here on the slide, starting with among different age groups, we did see that 45 to 54 age group and 65 to 74. Again, as a reminder, this is a Medicare population, so those who are under 65 do have different reasons for eligibility for Medicare, but good to see that in that group, as well as that pretty hefty 65 to 74 age group, that they had even more pronounced improvements in persistence from 2022 to 2023. We also saw in males specifically that they had a greater improvement than that 1.3%. And one of the greatest jumps among any subgroup was among those of Black race. So those individuals did have lower persistence levels at baseline, but did have the greatest improvement once this out-of-pocket cost cap went into effect, which was really promising to see. The last little subgroup analysis we did here was being able to look at census divisions. And so there were 4 in particular where we saw those greater improvements, so those being South Atlantic, East North Central, East South Central, and West South Central. And if you're not that familiar with census divisions, as I was not, we highlighted them on this map. And what was really interesting about this group was a lot of these census divisions overlap with what the CDC has defined as the diabetes belt, if you're familiar. So this is a group of over 600 counties that the CDC has noted have basically the residents of those counties have an increased risk of having type 2 diabetes or do have type 2 diabetes. So for these areas which are especially kind of at risk or ravaged by type 2 diabetes, they did have the most improvement when it came to looking at improved persistence in basal insulin from one year to the next. So like Christy said, kind of dialing down into these subgroups also gave us some more insights beyond just that one number at the top line, but give some insight as well to plans like Rebecca had mentioned, benefit design and other groups that are potentially most, I don't want to say susceptible to improvement or that are most likely to benefit from these cost-saving measures.
Yeah, I mean, the impact on reducing disparities, improving health equity is really obvious in some of these subgroup results. And that was really gratifying to us. The bigger changes were in the most disadvantaged, or socially disadvantaged populations. So let's now turn to the big question, who is listening to the patient? Who is listening to the consumer? I just was fortunate enough to attend the NCQA Quality Innovation Summit a couple of weeks ago. One of the keynote speakers was Mark McClellan. Anybody remember Mark McClellan? He was a CMS administrator, actually worked on some of the design of the Medicare Advantage program. But every keynote I listened to, including Mark McClellan, who said, the patient is the third leg of healthcare. It's the third leg and it's often missing. And that's why healthcare is sort of out of balance. And until we include the consumer's voice, the patient's voice, we're not going to improve. We're not going to get better. We're not going to have lower costs. We're not going to have better quality unless we, involve the patient in making decisions about their own health care. And so I'm going to, ask you, Rebecca, to please, comment about why. Why is it so important to ask consumers about about issues that, people might think, oh, that's the health plan's responsibility or the CMS's responsibility, or why is it so important?
It is absolutely their responsibility, but patients and caregivers together as a unit of care, I think, are such critical insight givers, as you described. And I thought that bullet around in your study that you didn't dive into, but is also one to lift up, is avoiding emergency room visits and hospitalizations. That's a key quality of life beacon that warrants sort of qualitative work as well, because as a health plan, of course, it's kind of a funny notion to think about consumer, because people, when they're sick, are disempowered and really not able to do window shopping. They are thrust into a world that's completely unfamiliar with terms that don't make sense. And the statistic that we highlight here is, if you talk about the third leg being patients and caregivers, the third rail of healthcare now is that health is also very dependent on financial well-being. And what the patients and caregivers that my organization tends to every day, those who are experiencing medical debt, who are experiencing challenges with insurance, prior authorization, denials, the things that they need a helping hand to guide them through and navigate. We have learned that financial hardship among those who are insured is very much a normal part of, it's a common condition of having a health condition, now more than ever, to the tune of 82% of the population we surveyed nationally this past year. These are people who are insured across the board, commercial insurance, employer-sponsored, all sorts of different arrangements, who are still the uncertainty of what prices, not just drug prices, but costs of care, costs of hospitalization, costs of long-term care, all the things that we're all having to grapple with as people across the country are very real. So our sample was very much a national representative sample of those who are from the different communities that were most benefiting from the certainty, the predictability of this insulin cap, for example.
And these are insured people.
These are folks who are insured, but just knowing that $35 is what I have to commit to this. It's just like in the insurance market. The death knell for people's household budgets is uncertainty, unpredictability, and sudden change, like a diagnosis, right? So price sensitivity is very real for people, especially those who are patients and their caregivers, to the extent that they are fortunate enough to have a caregiver and a family unit or some sort of friend unit that is supporting them. So I think the other piece that's so critical to think about is, if asked about what's important to them, it's often the answers may not be what you expect. Right. So this slide features the other part of the research we did among a nationally representative sample of patients and caregivers, largely who are insured, and from all different communities, rural, urban, et cetera, all different diseases. They ranked financial health, protecting their families and themselves from financial destitution or medical debt. They're more worried about that than dying. They're more worried about that than symptoms and side effects of their illness or the treatment complications that may happen. That's an aha moment, I think, for us to sort of grapple with, that financial health is as important as medical health and mental health in terms of insights that patients and caregivers are sharing. They don't have opportunities to come into rooms where decisions get made about how health plan benefit design happens, how their care happens within health systems, if we don't do the outreach, make them feel comfortable, recognize that their lived experience, expertise is right on par with everything that the doctors, the nurses, the social workers want to bring to the table in terms of their treatment plan, helping them to have predictability helping them to have financial well-being throughout this experience. That's really the name of the game for where policy has to head next, and helping them feel heard and understood in the process.
And so you have a little tick list you gave us.
I do, sort of the practical takeaway
You hear
tips.
from patients every day and you talk to caregivers. What do they care about? What do they really want?
Often it's much less about longer-term survival, the things that all of our quality measures typically focus on, to the exclusion of many other things in terms of quality of life. And now I will say financial health is a top-tier concern for them. It needs to be for us as well, as we think about what is the needs navigation support, that hands-on guidance that they all say they very much want to get through their illness with quality of life intact, with agency in their care, with having a say in how things happen, so that their financial well-being is on par with their medical well-being, their physical well-being, and their psychosocial well-being as well. And to help encourage them to share their lived experience expertise in every kind of setting, whether it's the treatment setting. They're wonderful advisors to help do benefit design, to help do price negotiation considerations about what really is the price point that makes or breaks whether I'm adherent or persistent.
Yeah, first conversation I had with Rebecca, she said, they don't want everything. People think they want, no, they want basic stuff that, is we all want, right? That we all would want to have. So ask the audience, how many of you were surprised by some of those statistics about what patients, are worried about? The economists call it financial toxicity, which sounds really scarier, right? But it's so scary. It is, and it's a huge problem. But how many of you were surprised by those, or was that a few people? I mean, I thought those numbers were pretty shocking and pretty stark. I'll ask another question of the audience. How many of you have either involved patients advocacy, patients in your, have advisory groups, or, give the patients a voice, give the consumers a voice? Does anybody have experience with that? Would you like to comment on what you've done? Do we have mics?
We help a patient fund their medical aid or sometimes Medicare. That's the service we provided.
Okay.
Yeah.
And I think we have a comment over here.
I actually work for Mayo Clinic, and I am one of the senior financial navigators there, and we actually match patients with programs like Patient Advocate Foundation, and also navigate insurance questions, drug questions, denials, everything that the different organizations are doing. We're doing it internally within Mayo Clinic.
That's great.
I'm so interested to hear just specifically how it's paid for within the Mayo Clinic. Is it part of the operational budget for the center?
It is. Initially, it was covered by revenue. We have now since had some of our employees be covered through FTEs through the clinical teams, because we do partner with clinical teams, the social work teams, as well as patient navigation. Primary focus initially was oncology. It was so successful, we were able to move into the other departments, and now we're actually starting a transplant process. So we have been very successful, and it has relieved a ton of financial toxicity for our patients. So thank you too for everything you do for the patients, because you are one of our greatest resources.
That's great.
I'm so glad to hear it, and I can't help but talk about the term financial toxicity, which got coined in oncology. And for patients and caregivers, it's a very stigmatizing phrase. Again, if you ask people, what are the words that we use that are resonant? Financial hardship is where they land as a critically important way just to invite them in instead of make them feel othered. I think, as you said, that toxicity is sort of and you talked about it in NCQA, people were talking about positive toxicity.
Yes, right.
It's catching like wildfire in a way, but the notion of having a financial navigator in the audience is a dream come true for me, because I want to replicate within the health system, everything that you do every day as a full-time job and the value that you bring that you've showed Mayo Clinic is worth investing in. I want that systematized for all patients because the real truth is that financial well-being and hardship is a very real outcome now that we have to pay attention to as all health systems, all health insurers, all people who are trying to do best by both the bottom line, but also what consumers need.
And that's what your study showed, Roseanne, about this measure, that it has far-reaching implications for healthcare costs. Emergency room cost treatments are very expensive. Inpatient care, really expensive. You can avoid any of that, right? Even a small, that's the biggest part of the healthcare cost, right? So you got to think beyond. And it sounds like I'm sure you're in the, sort of the financial area. You've had to show ROI on this program, right? And you've been able to do that, it sounds like, because you're broadening it, you're expanding it. So there's value, there's real value in putting these programs in place. Yeah.
Thank you for the work you're doing. I come from Monument Health in Rapid City. So I completely agree with you, and I would love to connect with you offline on the financial burden and the medical debt. I've done a lot of work. Our system has been very supportive. We actually converted around $22 million of bad debt into charity care through a very innovative process, because the major challenge is all the financial assistance programs, as you have seen, they have no control. Patients, first of all, when they are going through a medical crisis, and it's a patient-driven, the patients have to ask for all those forms and everything. Until that's completed, they cannot get the assistance. So I completely am very, very supportive, and it's a good resource for me, and I'll love to talk more. Thank you.
Great.
That's great.
That's great. Anyone else have any comments? What are the barriers? What do people think the barriers are to involving patients in benefit design and drug pricing and planning, their own care? Why is it hard to do? Yeah.
I think drug pricing is just a piece in the puzzle. It's a whole holistic system, the variation itself, the lack of and also overburden of regulatory oversight, how these programs could be implemented. Government has not given a clear guidance to the systems, but also systems are afraid that if we implement something, how are we going to be looked at? The payer contracts, the payers would not pay, it's a contractual thing that they just cannot write off things, the systems cannot. For Medicare patients, as you know, inducement is a big fear most hospital and healthcare systems face. So all those challenges, even though people are willing to help, the system is so difficult to navigate that how to help those patients, both at the front side, the middle end, and the back end. Yeah. So just my take on this.
Absolutely. Got it. Well, up here we have. Thank you.
So I actually, sorry. I ran a couple of member advisory committees as a requirement to have a dual eligible special needs plan in both New York and Indiana. So it's a state requirement. So bringing Medicare members in to just solicit their feedback and their experience with their Medicare plan. The challenge is really just getting them to show up, right? Yeah. And we tried to do these virtually, and that was a challenge, but just trying to, I don't.
Do you think it's because they think nothing's going to happen anyway? This is like a check the box.
Maybe. It's not their highest concern, their Medicare plan. So I think just the logistics of soliciting the feedback was always a challenge. I brought food and everything, and they never.
I feel like Rebecca might be able to help with some of that. All right.
There are two responses I'll share very briefly. One is, oftentimes for these folks, imposter syndrome is real. To be invited into a room where there are a lot of people with many credentials after their name. Engagement is a science, and there are opportunities to partner. My colleague Rebecca Angove and I, she's an engagement science expert, built the Patient Insight Institute to help support exactly this need, that there are people who have been trained to feel confident in sharing their lived experience expertise as equal to the others in the room, and so that outreach opportunity is possible. But also, even though it's hard, it's absolutely essential and worth doing. And there are pockets of people who care very much and are ready, willing, and able. And I'm a helpful contact for finding those people through our Patient Insight Institute, because we recognize that need and the challenge of finding people who are representative of the population as well.
Thank you. I thank you so much for joining us today, both of you. This has been a really engaging. I've learned something. I hope you all have learned something as well, and take home a little more excitement to, really not only talk about, price negotiations, drug price caps, but let's involve the patient and the consumer in their own care, and or things are not going to get better. Was it the Lorax that said that? If we, so thank you all for coming. We're out of time, but we're happy to answer questions after the session. Thank you.
Thank you.